Very good morning to all of you, and good afternoon and good evening to all of those who are joining from rest part of the world. Today, our guest speaker for the day is no other than Professor Dr. Andrew Davies from Southampton, UK, and he's going to lecture us on double and triple hit lymphoma, all you need to know in 2025. This webinar is brought to you by Mumbai Hematology Group, supported by Roche, Unipath, Lucent Life Sciences, and Nirvin Life Sciences, and managed by Perfect Square. I thank Team Roche, Unipath, Lucent, and Nirvin, Mr. Yash, Mr. Karpes, and the team Perfect Square, Executive Committee of Mumbai Hematology Group. Our chief guest for the day, Dr. Nathan Kurunakaran from Chennai. Our guest speaker for the day, Professor Dr. Andrew Davies from Southampton, UK. All our discussions were themselves very eminent hematologists as well as hemato-oncologists. And you participants for sparing a Sunday morning, afternoon, or evening from whichever part of the world you're logged in. Let me give a flavor of our next weekend activities. Next Saturday, that is 10th of May 2025 from 7 p.m. Indian Standard Time and 8:30 US Central Time, we have Professor Dr. Anand A. Patel from Chicago, US speaking to us on treatment strategies for older adults with ALL. And the following day, that is Sunday, 11th of May 2025 from 11:30 a.m. Indian Standard Time and 10 a.m. Abu Dhabi time, we have Dr. Farooq Shah from Abu Dhabi speaking to us on thalassemia, updates from ASH, December 2024. Let me introduce our discussions for the day, and they are displayed here in alphabetical order. I will stop for a while for you to have a look on all our discussions today. So these are our discussions for the day today. So now it's the time to introduce our guest speaker for the day. We have with us Professor Dr. Andrew Davies from UK. Dr. Andrew Davies is Professor of Hematological Oncology in the Faculty of Medicine, University Hospital Southampton, UK. He specializes in the treatment of malignant lymphoma. His work focuses on translation of biomarkers and novel therapies to the clinical arena. He has extensive experience in early phase trials, along with the delivery of practice-changing late phase studies. He is the chair of the UK NCRI Lymphoma Research Group. He is also director of the Southampton Experimental Cancer Medicine Center. He is also regional lead for cancers in teenagers and young adults. Today, he is with us and is going to lecture us on double and triple hit lymphoma, all you need to know in 2025. But before he does that, you have a special guest and chief guest for the day, no other than Dr. Parathan Karunakaran from Chennai. Dr. Parathan Karunakaran is Associate Professor, Department of Medical Oncology, Cancer Institute WIA, Adyar, Chennai. He did his MD Internal Medicine from PJ Chandigarh in 2009, followed by DM in Clinical Hematology from PJ Chandigarh again in 2014. And his areas of academic interest include lymphoid malignancies, chronic myeloid leukemia, as well as allogeneic stem cell transplant. It's my privilege to welcome Dr. Parathan Karunakaran to inaugurate our webinar and give some words of wisdom. Well, thank you so much. I stop over here. Over to you, Dr. Parathan Karunakaran.
Thank you, Kurana, for that kind introduction. So I'm going to be very simple here. MB Agrawal also told me that I will be talking about anything other than double hit lymphomas over here. So at the outset, I'd like to welcome the young minds of hematology who are keen to learn further, and also the not so young minds who are still learning despite of their age and position in life. We live in an age where there's an explosion of information. You have, I mean, if you had told me 7-8 years back that Mumbai Hematology Group is going to have a webinar every Sunday, I thought you'd be joking. But COVID has changed a lot. Back in our days, getting to learn from MB Agarwal sir would happen like maybe 3 or 4 times in a year. And it would be a physical meeting and we would all make sure that we were there. MB Agarwal sir is like, a teacher. Despite of us being studying in any institute, he was always like a teacher for us. His classes were always excellent, and it is a privilege and an honor to be speaking here on the Mumbai Hematology Group. I think COVID changed a lot, and I think the newer generation should be thankful to Wuhan Institute and coronavirus for having done that for us. So I get a lot of career counseling requests from people who have done their MD medicine and they don't know whether to choose hematology or not. And what I tell to them is what I'll tell you now, that see, hematology is not just one field. You have benign hematology, you have consultative hematology, and you have malignant hematology. And you will, whatever you want, you can get from it. If you are a person who's interested in continuing your practice of medicine, then your benign hematology and consultative hematology is something which will be very satisfying for you, where you get a lot of knowledge, you get to see a lot of patients, interesting approaches to diagnosis. If you're a person who's interested in those kind of things, a benign and consultative hematology is good for you. If you're someone who wants to learn the latest techniques, the newer techniques, CAR T cell therapy, bone marrow transplant, anything that is happening new, obviously malignant hematology is the place for you to be. And if you're someone who says that, no, I want to, I have studied so much, I want to start earning money, again, hematology is something there for you. So hematology is one field where it can satisfy both your academic interests, your technological advancement interest, and also satisfy you monetarily. So I would say, please welcome to the field of hematology. And with that short introduction, I will hand the mic over back to Amit Kurana. Thank you.
Thank you, Dr. Parathan, for that wonderful words of wisdom. That was quite meaningful for all of us. Thank you for accepting our invitation as our chief guest for the day. Thanks a lot.
Thank you.
Now, Professor Dr. Andrew Davis, the screen is yours. Please go ahead.
Great. Thank you so much. And thank you for such a very warm welcome. It's really great to be with you here this morning. And thank you for those really very kind and wise words. It's great to be back with the Mumbai Hematology Group this morning. I think, as you've said, that this has been an amazing access in terms of worldwide seminars. We've had some fantastic speakers. It's always a great privilege to be part of this. So once again, thank you for the invite. So this morning's topic sounds maybe perhaps a little esoteric, but we're going to talk about double and triple hit lymphomas. And this is a field that has shifted hugely over the last couple of years. And I think it's quite bewildering often in terms of the approach, and certainly for us at our multidisciplinary team meetings, when we have cases of double and triple hit lymphoma, there's always a vexing question of how we should optimally manage these patients. And I think the challenge largely comes not only from our evolving understanding of the biology and how our classification systems have changed, but also the fact that the evidence base for some of the decisions that we make in clinical practice in patients with triple and double hit lymphoma is really quite poor and largely based upon retrospective analysis. And as the field is evolving and moving quickly, it's quite hard for us to know exactly how we should optimally treat our patients. So I hope that I'm going to go some way to help improving your knowledge over the next 30 or 40 minutes. And I think we're going to have plenty of time for discussion afterwards. I just wanted to say to you that I've got a number of disclosures before I begin. So, we, prior to the 2016 WHO classification, so that the Heme4 version of hematological malignancies, we had various different sort of categories of high-grade B-cell lymphoma, Burkitt-like, large B-cell lymphoma, blastoid type, that were all kind of being described in a fairly difficult and non-reproducible way. And what happened in the 2016 classification is that there was some attempt to draw together these tumors that had commonality in biology. So for those patients who had a MYC or a BCL2 or a BCL6 rearrangement, so those with MYC and BCL2 and BCL6, or all three rearrangements, were lumped together in a single diagnostic category, regardless of the morphology, called high-grade B-cell lymphoma with MYC and BCL2 and or BCL6 rearrangements. And for those high-grade B-cell lymphomas that didn't fit into one of the other categories, these were put together, and lacked these oncogenic aberrations, or at least this pairing of oncogenic aberrations. They were lumped together in the high-grade B-cell lymphoma NOS category. And this was a very kind of rare diagnosis, but a fairly heterogeneous category. Now, these kind of put together a group of aggressive disorders with a propensity for aggressive clinical presentations, high stage extranodal sites, CNS involvement, and generally poor outcomes. And this is how we looked at this diagnostic group. And we can see that what got lumped into this high-grade B-cell lymphoma with MYC and BCL2 or BCL6 rearrangement were all these cases of Burkitt-like lymphoma, blastoid-like high-grade B-cell lymphomas, and diffuse large B-cell lymphoma that carried these translocations. And because, of course, there was this partnership of MYC and BCL2 or BCL6 translocations, they became known as the double hit lymphomas or the triple hit lymphomas. And they sort of undertook sort of this lumping that was really kind of independent, really about some of the biology. So let me just start by kind of trying to define these a little bit. So a double hit lymphoma is a high-grade B-cell lymphoma with a MYC and a BCL2 rearrangement or a MYC and a BCL6 rearrangement. Okay, they are generally considered to be de novo, although there may be transformation from follicular lymphoma. And as I said, they have a spectrum of morphology. The triple hit lymphomas we refer to have a BCL2, a BCL6 rearrangement as well, so all three oncogenic aberrations. The high-grade B-cell lymphomas, NOS, have those morphological features, but don't have those oncogenic aberrations that we've described. And then you'll probably hear us talking about double expressors, which have been deprioritized really in the latest iteration of the classifications. But these are types of DLBCL NOS that overexpress by immunohistochemistry MYC and BCL2, but they lack the oncogenic translocations. And I think that's a completely different biology that we're going to come back to later in the talk. And let me just give you a very, very quick brief outline. We recognize that if you've got translocation of MYC, we get overexpression of the transcription factor, which drives cellular replication, metabolism, drives enhanced efficiency of translation, and also sort of really changes the signal transduction picture. If you have overexpression of BCL2, of course, that's an anti-apoptotic protein, and overexpression of BCL2 will result in resistance to apoptosis. So when you've got a MYC and a BCL2 translocation, you've got this drive for cellular replication, and you've also got this protective effect from the overexpression of BCL2, which prevents apoptosis of the proliferating cell. And BCL6, just in terms of understanding the biology of BCL6 in terms of its oncogenic drive, is really perhaps less well understood, but it seems to have a significant role in cellular proliferation when it's and a modification of adhesion when it's overexpressed in cells. So we have these different oncogenic aberrations, and in the old classification, simply we took whatever the morphology was, and if we did a FISH analysis and we saw MYC and BCL2 rearrangement, they were lumped together in this single group, and that was our kind of framework for the way we would think about things. However, in the latest iterations of the lymphoma classifications, both the WHO and the international consensus classification, actually there's been a really good attempt to try and pull together the biology and commonality of the biology into a more genetic framework for us to think about the high-grade B-cell lymphomas. And this is a little bit confusing, I would say, and I don't think that maybe everybody's quite grasped this, either in the pathology field or also in the clinical arena. But let's think about here. We've got our double hit lymphomas, our triple hit lymphomas at the side. The first thing that's happened is that there's been an attempt to unify the biology. So these high-grade B-cell lymphomas that have a MYC and BCL2 rearrangement absolutely share commonality of biology, which I'm going to talk about a little bit more. And so now we think about high-grade B-cell lymphoma as a MYC or BCL2, and exclusively MYC and BCL2 in this single diagnostic category. If you've got a BCL6 aberration, you can add to that to a triple hit lymphoma. But really what the important thing in terms of driving the clinical phenotype is the fact that you've got a MYC and BCL2 translocation. BCL6 has become less important in terms of the double hit categorization. So we have a double hit, which is a high-grade B-cell lymphoma that shares MYC and BCL2 rearrangement. But the difficulty with this is that there's no commonality of biology. We're not entirely sure about the prognosis of these who have double hit lymphomas with BCL6 rearrangement. We don't really understand the basis for this, and therefore it's been somewhat deprioritized. And indeed, in the WHO classification, it's been really deprioritized, whilst in the ICC it's become a provisional diagnosis. So BCL6 double hit lymphomas have become less important as we try and shift and understand the biology. We have the double expressors, which I say lack the oncogenic translocations, but do overexpress protein. And that overexpression of protein is by a range of different mechanisms. And perhaps some of that is driven by microRNAs. Now, beyond FISH analysis, we understand that there are a group of high-grade B-cell lymphomas that have the same clinical behavior as those with the double hit lymphomas, those that have the FISH translocations, poor outcomes, GC phenotype, etc. But we can't see these translocations when we use FISH. And we think some of this is to do with cryptic translocations. And these has been called the dark zone lymphomas, and they're defined by transcription. And I'm going to come back to those in a little bit later. We then have the high-grade B-cell lymphoma NOS category. This is a diagnosis of exclusion, variable morphology, and they may have single MYC rearrangements, but they lack the double hit rearrangement. And essentially, this is a rare category, which is somewhat difficult for us to be able to work out what the best therapeutic approach for is. And then, of course, we have this much rarer category, which I'm not going to say very much more about during this lecture, the high-grade B-cell lymphomas with 11q aberrations. And these look morphologically generally fairly aggressive, but they lack MYC rearrangement. And when we look harder, we find that they often have 11q aberrations. So that's the new way of thinking about the double and triple hit lymphomas. We recognize that when we look at overexpression and we try and look at this in the context of the cell of origin model of the high-grade B-cell lymphomas, we take a range of tumors that have overexpression of MYC and BCL2 by immunohistochemistry. We can see that the majority of these will fall into the ABC phenotype, and a small group will fall into the GC phenotype. And actually, when we look at this in a bit more detail, the GCs are the ones that have the MYC and BCL2 rearrangement. So this is a subcategory of GC lymphoma. The double expressors are the ones that have the ABC phenotype. And I think that kind of distinction really helps us understand a little bit more about the biology. So when we talk about high-grade B-cell lymphomas with double and triple hit lymphomas, we see that they probably represent about 5% of the high-grade B-cell lymphomas. MYC and BCL2 is much more common translocation. They have, as I've said, they have a shared biology. The pattern of mutations are very similar, and they have a kind of intermediate frequency of various mutations, somewhere between that of Burkitt lymphoma and diffuse large B-cell lymphoma. Those with a MYC and BCL6 translocation represent about 20% of this double hit category. A whole range of different mutations and great heterogeneity in the pattern of mutations. And the triple hit lymphomas are really much rarer, and we really don't understand much about the biology of these tumors. And when we look at a pattern of patients with diffuse large B-cell lymphoma, we probably see that MYC rearrangements occur in about 10 to 12% of cases. We see single MYC translocations, which probably are not associated with an adverse phenotype in about 5% of cases. We say MYC BCL2 in about 5%, and then much rarer we see these aberrations that involve MYC and BCL2, either as a double or a triple hit lymphoma. So I think the whole framework is somewhat more complicated. And when we think about how we've reanalyzed the BCL6 double hit lymphomas and the BCL2 double hit lymphomas, as again, I can say this is from the WHO classification, we can see that MYC and BCL2 rearrangement, absolutely similar shared biology, but the BCL6 is less clear. And as a result, in the international consensus classification of lymphomas, really the MYC-BCL6 has been put as a provisional entity called high-grade B-cell lymphoma with MYC and BCL6 rearrangement, really why we try and work out some of the biology. And in fact, actually, what we have seen is that the data involving BCL6 is quite complicated, because often we might see pseudo double hits where we see a translocation to MYC where actually BCL6 is the partner, and that pseudo double hit really kind of affects the literature, and we're really not entirely sure about the significance of these. So I'm sorry that this all sounds quite confusing. This slide just is data that demonstrates that the BCL6 driven double hit lymphomas have a really heterogeneous pattern of mutations and also partner translocations, again exemplifying the fact that the biology is not shared, unlike the BCL2 MYC aberrations. Now, what about defining prognosis? Well, if you take a large group of patients with large cell lymphoma and you look at, by doing FISH, and you look at MYC translocations, we can see that those patients who have a single MYC aberration have a very similar progression-free survival and overall survival as those patients who don't have any MYC translocations. But in the red lines, you can see the outcomes for those patients with double and triple hit lymphomas. And we can see that that's worse, particularly in the first 2 years after sort of diagnosis. However, when we look at these modern curves based upon population analysis rather than just doing MYC screening on our highest risk patients, we can actually see that the prognosis is perhaps much better now than we had previously have thought. Now, if we look at the bottom two curves, these give us the prognosis of patients with BCL2 double hit lymphoma, BCL6 double hit lymphoma, and triple hit lymphoma. And we can see both for PFS and overall survival, they are quite similar. So I think, you know, we recognize that's associated with an adverse prognosis, but perhaps the outcomes for the different oncogenic aberrations is perhaps not different. Now, not only is it important in terms of performing the FISH analysis to identify, once you've seen that there's a MYC translocation, that you identify whether there's BCL2 and a BCL6 translocation, but actually trying to identify the partner for the MYC aberration is really important. So for those patients who have a partner translocation with a non-immunoglobulin gene, what we see is that the outcome is not inferior. It's only those double hit lymphomas where MYC is partnered with an immunoglobulin gene in the translocation, and that's associated with a poor outcome. Now, this data is a little bit controversial. The numbers of patients in these categories is relatively small, but I think you should always ask your molecular diagnostic laboratory to say, tell me what the partner is of the MYC translocation once you've identified, because it can really help frame your question. And actually, what I do in my own clinical practice is I only intensify therapy for double hits when I do know that there is a partner of the MYC translocation with an immunoglobulin gene. So I do recognize, of course, you know, with this wider spread use of FISH analysis, this is a really resource intensive approach. And the question is, do you think there are any surrogates for FISH analysis? And should we be selecting cases out for FISH analysis where we have to worry about our resources being available? And of course, you can use some surrogates by saying, I'm only going to perform FISH analysis once I've demonstrated overexpression by protein of MYC and BCL2, and I'm only going to do this in a GC phenotype. And that will generally give us a fairly good estimate of which cases are going to have MYC positivity. But actually, you know, that does lack some sensitivity and specificity. And because of our new way of thinking about the high-grade B-cell lymphomas, I would really say that performing FISH analysis across all diagnoses actually gives us a really helpful insight into be able to do this. But I do recognize that these may not necessarily be available, and you may have to be more selective in cases you wish to select for further FISH analysis. Now, I just want to take a few slides just to take a deeper dive into the molecular analysis underlying these tumors. And this nice piece of work, which was done by the Vancouver group, took a group of tumors that had been defined by FISH analysis to be double hit lymphomas. And they did a transcriptional analysis, of the double hit lymphomas, and also a much larger panel of GC type GC lymphomas that did not have MYC aberrations or had BCL2 or single MYC aberrations. And they found a certain transcriptional signature that was associated with the double hit phenotype, the so-called double hit signature, and that contained 104 genes. And when you applied that to a whole broader range of GC diffuse large B-cell lymphomas that lacked FISH-defined oncogenic translocations, what could be seen was that a group of patients had the same transcriptional profile as double hit lymphomas, but they didn't have any translocations of MYC or BCL2. And these have so-called been called the double hit signature, or indeed the dark zone lymphomas. And these are GC, aggressive B cell mature lymphomas that have a transcriptional profile the same as the double hit lymphomas and the same poor clinical outcome as the double hit lymphomas, but actually they don't have a translocation identified by FISH. And if you look with next generation sequencing, you can see that many of these tumors actually do have some form of MYC and BCL2 cryptic aberrations. But really what we've identified now is this new group of tumors called the dark zone lymphomas, which are GC lymphomas, mature markers, have a very aggressive clinical phenotype, and they probably represent up to 20% of the GC large cell lymphomas. And in our own studies in the UK, we've also identified this, and we called this the molecular high-grade lymphoma. And really what we've done is we've come together and we put this under a single umbrella called the dark zone lymphomas. So they include the MYC-BCL2 double hit lymphomas and those with the same phenotype but lack the FISH aberrations. Now, the BCL6 ones, as I say again, complicated. The biology is not uniform. There's all sorts of data about the prognosis of double hit lymphoma where there's BCL6 aberrations. Perhaps they have worse outcomes, but really the data on this is really out and still for discussion. It's a massive area of active research to try and work out whether BCL6 double hit lymphomas do actually have a worse prognosis. And just before I finish on the biology side of things, just one thing to say: in the previous classification of the high-grade lymphomas, as soon as you saw TDT expression, these were kind of put automatically into the B-ALL category. Now, that's not entirely the case, and actually what we've come to understand is that TDT expression, which may occur in up to 10% of the high-grade lymphomas, it really is just a secondary event and doesn't indicate that these, if you see TDT positivity, that these are immature tumors. We just believe this is a secondary event. When we see this in patients with high-grade lymphomas of a mature phenotype, we see that they don't express CD34. They have mutation profiles that are very similar to the high-grade B-cell lymphomas, and they are not a form of ALL. So they've been recategorized in the latest iterations of the classifications. So just seeing TDT expression is not a de facto evidence of immaturity, and therefore different approaches should be taken. So let's just go back. Let's just remember that genetic framework of how we think about this. And I'm sorry, it's somewhat confusing. And certainly this is a picture that the biology is very rapidly emerging in these double and triple hit lymphomas. And this has just been recently published in Human Pathology. And I think it's a really nice snapshot of thinking about how we should describe diffuse large B-cell lymphoma, NOS, the MYC-BCL2 driven double hit lymphomas, and the high grade B-cell lymphomas, NOS. Now, let's move on to the clinical stuff. Let's think about the clinical relevance of knowing whether patients have double hit lymphomas. Well, as I say, that probably represent about 5 to 10% of lymphomas. And we've all been very used to thinking about double hit lymphomas having curves, outcome curves that look like that. So in a rapidly aggressive clinical course, patients presenting with advanced stage disease, typically poor performance status, bone marrow involvement, other extranodal sites, high lactate dehydrogenase, high IPI, and also the risk of CNS lymphomas. However, all of these reports that we have seen really have been based upon retrospective analysis, that they've been based upon data from academic referral centers, and they've really been the worst of the worst. And until really we saw the introduction of the reclassifications in 2016, 2017, really, this was largely based, the FISH analysis for double hit lymphoma was based upon analysis in the worst of the worst cases, rather than screening for these aberrations on a population basis for any patient who'd been diagnosed with a high-grade B-cell lymphoma. The main sort of themes that we have around the treatment of the double hit lymphomas is that really we should think about a clinical trial for these patients, and because we know so little about them. However, that's difficult because often these patients present with rapid disease kinetics. They may present unwell, and obviously having trials available for a rare patient population is difficult. The logistics of trial delivery with low frequency is a real problem. So although we say we should be looking at these patients in clinical trials, actually the practicalities of getting them onto a clinical trial is really difficult. There's no established standard of care. We think we should probably be intensifying patients in terms of our therapeutic approaches, but that's really quite controversial. The data sets that we are making those decisions on are largely retrospective, and as I say, they come from times where our approach was very different. I think we recognize that R-CHOP has been associated with inferior outcomes of these patients, and we've looked to try and intensify treatments. We wonder what's the role of high-dose chemotherapy and transplant consolidation in these patients, and do we really believe that these patients are at higher risk of CNS disease? So we accept the fact that we get less than good outcomes with R-CHOP chemotherapy in these patients. And because in Burkitt's lymphoma, which is driven by MYC aberrations, we see good outcomes with intensified schedules, it's only been natural for us to try and investigate some of these Burkitt-like regimens in patients who have double and triple hit lymphoma. But there is a massive lacking of randomized prospective data because it's such a rare event. And some of the data that you may see presented may be the fact that these patients are highly selected. So let's sort of take the first place, and let's go and have a look at this argument for intensification of therapy. So let's just start off with some of these retrospective data. Well, we can see this is data that comes from 23 US centers. It's sort of over 10 years old now, and it demonstrates that those patients with double hit lymphoma who had intensification regimens such as dose-adjusted EPOCH, R-CODOX-M, IVAC, hyper-CVAD had a higher complete response rate than those patients treated with R-CHOP chemotherapy. And actually, they had a superiority in terms of progression-free survival with an intensified induction regimen over R-CHOP chemotherapy. However, there was no difference in overall survival between those patients treated with R-CHOP and those who received an intensified induction therapy. A single center analysis from the MD Anderson also demonstrated perhaps the superiority of more intensification over R-CHOP chemotherapy. The red is the R-CHOP chemotherapy arm. The blue is the dose-adjusted EPOCH arm, suggesting superiority of outcomes, and that perhaps some of the other intensified regimens were perhaps detrimental to patients. And there has been a small meta-analysis that was published now some 10 years ago comparing dose-adjusted EPOC to other dose-intensified regimens and comparing this to R-CHOP chemotherapy. And we can see the solid line is the R-CHOP treated patients. The dotted line at the top is the dose-adjusted EPOC arm. And actually, it suggests that those patients in this meta-analysis do better, again, if they have dose-adjusted EPOC. However, there are many challenges around this meta-analysis. There's little in terms of individual patient data. There's a lack of clarity about the baseline prognostic data of the patients going into these different groups. So there are very many challenges around this meta-analysis. And there's only one prospective study of dose-adjusted EPOC in patients with MYC rearrangements, of which 50% of patients had double hit lymphoma. This was conducted at the National Cancer Institute. So I will say that this is a selected patient population because they need to get to Bethesda in the US to be able to participate in this study. But it did demonstrate in those patients with double hit lymphoma, as shown by the blue lines, that actually very good outcomes could be achieved in selected individuals with a event-free survival at 48 months of 73% through the use of dose-adjusted EPOC. And really, I use this as the basis for my practice decisions because I like to use dose-adjusted EPOC in patients with double-hit lymphoma who are younger and fitter. But do remember the challenges around toxicity with dose-adjusted EPOC. You are trying to induce cytopenias because this is a pharmacodynamically modulated approach. We recognize that neuropathy may be a problem in these patients. We recognize cumulative anthracycline doses can also be a challenge for these patients. So those patients who are older, the ability to tolerate dose-adjusted EPOC is certainly much less. But certainly for my younger, fitter patients who have double hit lymphomas, then certainly dose-adjusted EPOC is my preferred therapeutic approach. Now, when I say that, a lot of people sort of shout out and say, well, what about the SWOG study that compared R-CHOP with dose-adjusted EPOC? And this demonstrated no difference in event-free survival and overall survival. Now, this was a big study. It was all comers with large cell lymphoma. And actually, the number of patients who had MYC rearrangements and indeed double hit lymphoma was really very small. So we can't select out any conclusion from this study. So we can't say that R-CHOP and dose-adjusted EPOC are equivalent in the patients with double hit lymphoma. There is some very nice data, however, based from population bases of the US Flatiron Registry, and this is insurance-based analysis that compares R-CHOP outcomes with dose-adjusted EPOC in a more modern era. And you can see in the blue line, that's the outcome in terms of overall survival from dose-adjusted EPOC, and in the black solid line, the outcomes from R-CHOP chemotherapy, and it suggests that there is an improvement. However, the balance of the baseline demographics in this patient population do not essentially match. And of course, more patients who are older were receiving R-CHOP compared with dose-adjusted EPOC. But there is perhaps a weak body of evidence, I should say, from retrospective analysis, real-world experience, and that single prospective study that for younger, fitter patients, we should probably be aiming to deliver these patients dose-adjusted EPOC if our infrastructure allows us to do that, because of course there are many challenges associated with delivering dose-adjusted EPOC. Okay, so what in the modern era where our approach to large cell lymphoma is changing, is there a role for some of the novel agents in the first line therapeutic approach? Of course, polatuzumab, antibody drug conjugate targeting CD79A, has been associated with an improvement in progression-free survival in the POLARIX study when added to polar R-CHP chemotherapy when compared to R-CHOP chemotherapy. This is a modest improvement in progression-free survival and no improvement in overall survival. And patients with high-grade B-cell lymphoma and double-hit lymphoma were included in this study, although over 80% of patients had diffuse large B-cell lymphoma, NOS. And when we look at the analysis for heterogeneity along these different histologies that was performed by the FDA, we can see that the effect size for adding polatuzumab to patients with double hit lymphoma, here shown in the middle, actually is quite strong, and it really favors adding polatuzumab in those patients with double hit lymphoma, both in terms of progression-free survival and overall survival. This bar here represents all of the other rarer types of large cell lymphomas, and they represent probably, I think, just 2% of the patient population, so that they're pretty uncommon. The double hit lymphomas represented about 10% of the patients going into the POLARIX study. So for my mind, if it's available, and we have older patients who we don't think about the tolerability of dose-adjusted EPOC, actually Pola R-CHP represents a very good option for these patients. And if we look at the analysis from the POLARIX study, of those patients who had a germinal center phenotype, and we look at the dark zone signature patients. So this is where our double hit lymphoma patients sit, representing about 22% of the whole GC population. So dark zone signatures, that's double hits, plus also those that don't have double hits by FISH but have the same transcriptional profile. Actually, these patients shown here in the orange clearly benefit from the addition of polatuzumab. So I think that there's a strong argument for our dark zone signature patients or our double hit lymphoma patients to be exposed to polatuzumab if it is accessible and dose adjusted EPOC doesn't present a viable option to them because of toxicity. Now, this complication in the first line approach to the high-grade B-cell lymphomas with MYC and BCL2 and BCL6 and those with the NOS, the NCCN guidelines are really unclear and gives us a whole range of different choices that we might want to use for these patients. So really for me, just in terms of my way of thinking about this, if we've got double hit lymphoma, MYC, BCL2, I'm going to give them dose adjusted EPOC. If they're younger, if they're older, I'm going to give them Pola R-CHP. For those patients with MYC and BCL2 aberrations, the adverse phenotype is perhaps less certain. Again, I like to use dose-adjusted EPOC for these patients because there is a small amount of data suggesting that they do benefit from intensification. And for those patients who have high-grade B-cell lymphoma NOS, then again, probably dose-adjusted EPOC represents the best approach for those younger patients. But the evidence for this rare group is really quite small indeed. What about patients who present with double hit lymphoma with limited stage disease? And we're increasingly recognizing this problem because, of course, we are doing more FISH analysis in our molecular diagnostics. We're not just doing this in the patients who are presenting with poor risk disease. So increasingly, we are seeing this in patients with limited stage disease, the presence of double hit lymphomas. And I think there are two messages from this. One of them is to recognize that probably intensification of therapy really doesn't help these patients with limited stage disease. So the numbers are small, and you should probably take the same approach in limited stage disease as you would do for large cell lymphoma NOS. No clear recommendation. Now, the vexed question about CNS prophylaxis in patients with double hit lymphoma. The retrospective data suggested that there was a clear increase in incidence of CNS disease in patients with MYC and BCL2 translocations or double hit lymphoma. Now, the basis for this was not clear. And the reason it's not clear is because these are patients that presented with multiple other high-risk features for CNS disease, such as multiple extranodal signs, high lactate dehydrogenase. And so was this a question about the biology, or was it simply about the risk of the presentation of the disease? So we've got this sort of mantra that we see a much higher risk of CNS disease. And indeed, this was up to 13% in the MD Anderson series at 2 years. And we also asked the question about what was the role of CNS prophylaxis in these patients. And when we looked at the retrospective data, we saw that the outcomes for those patients who had methotrexate containing prophylaxis had a much better outcome than those patients who didn't have methotrexate containing CNS prophylaxis. Now, of course, the bar and the views on methotrexate prophylaxis to prevent CNS disease in high-grade lymphomas has been changing. And when we look at this very large series that was presented by Kat Lewis of almost 2,500 patients, the jury was really out in the large cell lymphomas as to whether high-dose IV methotrexate added anything in terms of preventing CNS disease compared with no CNS prophylaxis. But actually, the challenge with this is that although the numbers are large, when actually we delve into some of the subgroups, the clinical and biological subgroups, we can actually see some differences that may be relevant. And one of those particular differences is the difference between those patients with DLBCL, NOS, and those patients with high-grade B-cell lymphoma. And actually, it really looks like those patients do have some benefit from CNS prophylaxis. So my approach to this is always to try and deliver CNS prophylaxis for these patients. And I particularly am focused on this in younger patients. So for those patients who have double hit lymphoma, I always do a baseline lumbar puncture and an MRI scan to look for occult CNS disease at presentation. And after having completed induction dose-adjusted epoch, I like to offer them 2 cycles of IV methotrexate as CNS consolidation. Now, we can argue about whether how strong the evidence base is for this, but certainly this forest plot really helps guide me in that decision making. Now, of course, when I think about CNS prophylaxis, I'm always cautious about the toxicity of it, and I don't offer it to patients who have any degree of renal dysfunction, third spacing, hypertensive kidneys, and particularly I don't offer it to those patients generally who are over the age of 70. Now, just very recently, we have seen this analysis of double hit lymphoma CNS events. We can see that this has come from the Canadian group, demonstrating that 3/4 of CNS events are leptomeningeal, compared with only about 1/4 being deep parenchymal recurrences. And actually, in the modern era of molecular diagnosis, the rate of CNS events is much lower than we'd initially reported, and the rate is about 6%. And I would really encourage you to look at this article in Blood that has just been very recently published. So yes, give CNS prophylaxis. Is there a role for high-dose chemotherapy consolidation of first remission? Probably the answer for that is no. There's no kind of proof from the retrospective series that it does have an impact on progression-free survival and overall survival. But there was a very interesting landmark analysis to suggest that there may well be some benefit from high-dose chemotherapy consolidation in first remission if patients had had suboptimal induction therapy. So for those patients who had R-CHOP induction therapy, there may have been a benefit from having an auto in first remission. You can see over here the curve on the left-hand side. You can see in the blue, those are the outcomes of patients treated with R-CHOP chemotherapy. And if you gave R-CHOP chemotherapy and an auto, the curve now on the yellow side is pushed up on the right-hand side. So it may well improve the outcome for patients who've had induction R-CHOP chemotherapy compared with any of the intensive induction regimens where it's certainly not needed. Now, I think this data is probably a minimal practical relevance because, of course, you chose to give R-CHOP chemotherapy because the patient was probably older and less fit, and therefore they're going to be less able to undergo autologous stem cell transplantation. Now, of course, the difficulty for these patients is if these patients do relapse with double hit lymphomas, we see very poor outcomes. And I think that we need to really be focused on how we improve the outcomes of these patients. Prevention of recurrence by consolidation with an allo transplantation. I think the data is not great for allo transplantation, even the highly selected patient population. And it's certainly something I wouldn't recommend in first remission for patients. These are a highly selected group of patients. The non-relapse mortality remains high, and the outcomes, I think, really disappointing in terms of progression-free survival. So I don't believe in the modern era there's much of a role for allo transplantation. Now, what about the use of CAR T-cell therapy in patients with double hit and triple hit lymphomas? Well, if we look at data from some of the pivotal studies, this is data from the Juliet study looking at T-cell demonstrating that the effect size in those patients with double and triple hit lymphoma was very similar to the patient population who lacked the oncogenic aberrations. And I think this is important because, of course, this is mechanistically working in a way that's independent of the resistance of chemotherapy that we may see with double hit lymphomas. And of course, as we think about using CAR T-cell therapy in the second line setting, because of the superiority of CAR T-cell therapy over reinduction immunochemotherapy and stem cell transplantation, the data from the ZUMA-7 study and the data from the Transform study in this adoption in those patients with refractory disease or who relapse within 12 months, we ask about the question about the relevance in the high-grade B-cell lymphomas, the double or triple hit lymphomas. When in these pivotal studies, the number of patients with high-grade lymphoma or double hits was really very small. In the ZUMA-7 study, just 17 out of 359 patients had high-grade B-cell lymphoma. In the Transform study, looking at lisocabtagene, there were a few more high-grade B-cell lymphoma patients, but this was still 43 out of 184. So it's really hard to draw any conclusions about the effect of CAR T cells in the second-line setting in these patients, but we can delve into the forest plots from these two pivotal trials, and you can see I've outlined those here in the red, but largely the effect size from in high-grade B-cell lymphomas is very similar to the whole population in the whole study. So I'd certainly believe that for those patients who do relapse and relapse early, if accessible, CAR T cells certainly are an appropriate therapeutic modality. And we've seen some data from the French DECAR registry just very recently published, indicating that perhaps those patients with high-grade B-cell lymphoma may have a worse outcome than those patients who don't have the translocations. However, this may well be not due to the CAR T cell itself, but actually about the kinetics of the disease at relapse. So the top two curves demonstrate overall survival and progression-free survival from the time of eligibility. So from the time the physician first thought about CAR T cell therapy. And the bottom two curves look at the outcomes from infusion. The double hit lymphomas are shown in the red, the non-translocated patients are shown in the blue. And you can see that there's some difference in the curve when we look at the time from eligibility. But actually, if we just look at those patients who have CAR T cell infusion, the outcomes look very similar. So I think we can derive from this information to say that obviously these patients may have more rapid kinetics, but actually their outcomes are very good if we get to the point of reinfusion of their CAR T. So of course our outcomes and our therapeutic algorithms have been changing significantly for relapse and refractory high-grade lymphomas and large cell lymphomas. These are the new guidelines from the British Society of Haematology, demonstrating that we should be using the CAR T cells for those patients, excuse me, who relapse early, and chemotherapy for those patients who have later relapse, and also tries to incorporate some of the other novel therapeutics. What about using CAR T cells in these high-risk patients at presentation? Well, the ZUMA-7 study asked the question, I take patients with double and triple hit lymphoma who also have a high IPI score, and then we give them induction immunochemotherapy with R-CHOP or dose-adjusted EPOCH, and then we do an interim PET scan. And if that interim PET scan is positive, then perhaps we should be offering those patients CAR T because they've got multiple adverse risk features. And for those patients, it's a small number of patients. It's only 40 patients performed in US academic centers. And for those patients, the outcomes were really very good in those patients who had CAR T cells in the first-line setting. Now, the role of first-line CAR T cells in high-grade lymphomas is currently being investigated in the ZUMA-23 study, which is randomized, and it's not based upon distinction depending upon the biology or positive interim PET scans, but really based upon the IPI score for these patients. So there may well be a role for first-line CAR T cells in some patients, but I will say that's probably fairly limited. But of course, you recognize that delivering CAR T cells is massively problematic. We recognize the infrastructure that you need, the training, the resource, the economic, the social consequences, and the long-term toxicities of CAR T cells are a massive problem. So what about some other approaches? Well, a range of other novel agents have been looked at in double hit lymphomas in combination with dose-adjusted EPOCH and R-CHOP chemotherapy, unfortunately with little in the way of success. However, there has been some interesting data from the from the Dutch HOVON group looking at the addition of lenalidomide to R-CHOP chemotherapy in patients with MYC translocated high-grade lymphomas, including double hit lymphomas. And actually, they demonstrated an improvement in outcome better than would be expected compared with historical controls. So in some territories, an approach of using lenalidomide with R-CHOP is adopted for those patients, but it's based on a fairly small data set and it's compared with retrospective analysis. This is not the approach I take. So what about the role for bispecific antibodies in the patients with high-grade B-cell lymphomas double hit? Well, of course, there are a number of bispecific antibodies that have been investigated targeting CD20 and CD3 that are now coming to the market and are available in some territories. When we look at the pivotal study of glofitamab in patients with relapse lymphoma, this included a group of patients who had high-grade B-cell lymphoma, NOS, and double hit lymphoma. The numbers in this study are relatively small, but they probably represented about 10% of the 150 patient population. So not an insignificant number of patients. And we saw a complete response rates in the relapse setting of about 40% and certainly durability of benefit. And that appears to be the same for those patients with the high-grade B-cell lymphoma. And once again, of course, the attraction of this is it's a chemotherapy independent mechanism of action. So that resistance to chemotherapy that has been seen with these oncogenic aberrations may well be overcome. So next question is, of course, we've now seen the STARGLO data, which in the second line setting and the third line setting looked at adding a bispecific antibody to GemOx chemotherapy. And that this data demonstrates an improvement in overall survival. So what about in high-grade B-cell lymphomas? You're thinking about using bispecifics earlier on in the treatment algorithm. Well, I will say to you the very key message from the STARGLO data is that not one single patient with high-grade B-cell lymphoma, double hit, triple hit, was included in this analysis. So be cautious in interpretation of this data. What about adding a bispecific to reinduction chemotherapy? The glofitamab R-ICE study, really nice study, single-arm interventional study, included a lot of patients with high-grade B-cell lymphoma double hit and high-grade B-cell lymphoma NOS. Of course, it's a single-arm study. We know a little bit about the outcomes of these patients, demonstrating very high response rates, and the response rates were very similar in those patients with high-grade B-cell lymphoma and the rest of the study patient population. So this may be a potential option that we might be exploiting in the future. So as I come towards the end of my talk, I'll just go back to this genetic framework of how we should think about the high-grade lymphomas, how we should think about double and triple hit lymphomas, and move on very briefly to this rare category of high-grade B-cell lymphomas not otherwise specified. This is a small subset with morphological findings overlapping the double hit and triple hit lymphomas, and they may carry a MYC rearrangement, but they do not carry a BCL2 or a BCL6 translocation. So they stand on their own because they don't have the biological features that we would expect to see. So they are often Burkitt-like in morphology, less commonly blastoid-like in morphology, and it's clearly a diagnosis of exclusion. You can only put a tumor into this NOS category when you've done the FISH analysis and you've moved them on. It should be much less than 1% of your cases. And what to do with these patients in terms of intervention is really quite limited, but we think that they probably benefit from intensification. We've just seen published online now some data that's tried by the LMPP group group led out of the NCI, some attempt to really try and understand the patterns of biological aberrations in high-grade B-cell lymphoma, NOS. It's difficult. It's clearly very heterogeneous indeed. And I think that this is a lumping group of patients where we can't really find any uniform biology. What about the double expressors? Remember, these are the ones that have overexpression of MYC and BCL2 by immunohistochemistry, but lack the oncogenic MYC and BCL2 translocations. These were initially thought to represent a group of patients with a particularly poor prognosis. However, actually, it's become recognized perhaps that prognosis now is not quite so adverse, and there's in the bottom curve this just demonstrates some data from our own large study performed in the UK. And so in the latest iterations of the lymphoma classifications, this sort of categorization has been deprioritized, and it doesn't exist as its own entity. So it just perhaps represents some biomarkers of less good outcome. And I would certainly say for you, for double expressors, really R-CHOP chemotherapy represents the standard of care. Now, of course, the landscape in therapeutics for the high-grade lymphomas is changing rapidly. We've seen a load of studies over the last 20 years, and we've probably got something like 10 phase 3 studies that we are expecting to report looking at novel agents in combination with R-CHOP chemotherapy that are going to include patients with double hit lymphomas. They may be R-CHOP with a bispecific, they may be a first-line CAR T-cell, they may be small molecules such as golcadamide or acalabrutinib, or they may be antibody-drug conjugates such as zilovertamab. All of these are potentially going to change the therapeutic landscape. And actually, it's really important that we look very carefully at the analysis for those patients with high-grade B-cell lymphoma double hits to see what lessons we can learn from these patients. So here we are, 2025. What do I need to take home for double hit lymphoma? Well, the biological understanding of this group is really becoming unraveled, and it sounds very complicated in terms of the classification, but it's certainly moving very quickly. If you do have access to FISH, do FISH in all cases of high-grade lymphoma so that you can understand the biological classification and you can give some patients some idea about prognosis, and you can also make therapeutic choices. But sometimes FISH takes a long time, and really you should talk to your cytogenetics laboratory to really make sure that you can deliver FISH in a timely manner so that you can make therapeutic decisions early. I will say, based upon limited recommendation, limited data, if you've got younger, fitter patients, I would offer dose-adjusted EPOC, and I would always remember attending to the central nervous system in this group of patients. For double expressor lymphomas, R-CHOP chemotherapy is an entirely reasonable approach. Second-line therapies, outcomes are poor with conventional chemotherapy and stem cell transplantation consolidation. The outcomes for CAR T cells look actually very successful. Again, there's challenges around access for these and the socioeconomic consequences of CAR T cells. The picture in terms of bispecifics is clearly evolving. So the field is not standing still. I think we'll be certainly using more sophisticated and hopefully less resource intensive approaches as we define this difficult biological and clinical category. Thank you so much for listening. I hope I haven't left you too confused, and I hope I've left you with some very clear recommendations for your own practice. I look forward to the discussion.
Thank you so much, Professor. Wonderful talk. It was quite crystal clear, and it's just an eye-opener for all of us regarding this double hit and triple hit lymphomas, or how should we practice in 2025. Well, I request all our discussants to please put the raise hand sign so that we will start our question answer session with Dr. Andrew Davis. So, in the meanwhile, when the questions start, sir, I have a question for you. Those patients whom we diagnose it as a case of double hit lymphoma, older age, unfit for dose adjusted R-EPO, and we opted for Pola RCHP. Is it required that we must go for CNS prophylaxis for such patients when patient is already on Pola?
Yeah, I think that's a really good question. So in the Polarix study, the event rate in terms of the CNS was identical in those patients treated with polar R-CHP to those patients with R-CHOP chemotherapy. So there's probably no evidence to say that the addition of or the substitution of polatuzumab results in a reduction in the CNS event rate. So for those patients who have polar R-CHP, who are a bit older, then I would have a discussion about CNS prophylaxis in these patients. Now, often some of the factors that made me choose polar R-CHP over dose-adjusted EPOCH may be relevant in our decision about CNS prophylaxis, because of course, you know, there may well be that they have a reduced performance status or other comorbidities that may put me off offering IV methotrexate. Because I certainly, my view about CNS prophylaxis with IV methotrexate is that we want to do no harm where we've got an intervention that is perhaps we can discuss maybe of some question in terms of benefit. So I offer few of those older patients IV CNS methotrexate because I just worry about the toxicity when the intervention is of some dispute in terms of the effectiveness. I hope that makes sense.
Perfect, sir. Thank you so much, sir. Dr. Abhishek Sharma, your question, please.
Yeah. Good morning, sir, and
Good morning.
Thank you for the wonderful talk, starting from the biology to the treatment, conventional and newer therapy, including transplant as well as CAR-T. I have two very basic questions, sir. So how frequently do you consider bone marrow examination as a part of diagnostic workup or for staging in cases of double and triple hit lymphoma? And what do you offer? Do you offer a unilateral or a bilateral trifine biopsies for these cases? And my second question,
yeah, go on.
Yeah. My second question is you mentioned about pseudo double hit finding. So how can we go ahead to differentiate between pseudo double hit and true double hit by FISH? And so how frequently you are using TDD in your conventional panel, especially when you get a blastoid morphology of a lymphoma cases? As you mentioned, and it is documented that 10% cases can have TDT expression, however, they are CD34 negative.
So thank you so much, and some really important questions. I must admit, I've completely moved away from doing bone marrow examinations in patients with high-grade lymphoma. I do a baseline staging PET scan, and only really I reserve a marrow examination for patients who've got an abnormal peripheral count at presentation or a signal that is indicative of bone marrow involvement on the baseline PET scan. So I do, in fact, I do very few bone marrows now across the whole of my practice, and that's mirrored, I think, pretty much my colleagues do the same approach. The next question really about the pseudo double hit. I think this is fascinating. I think this is something that we don't really understand. And I think we've seen that probably about 40% of patients who have a MYC and BCL2 double hit actually have a translocation that involves the two together. And I think the way we work that out is really by having good conversations with our cytogeneticists who are really keen to try and understand whether the partner of the MYC translocation is an immunoglobulin gene or not, and they can help dissect that out. And really, I think it's really important for this discussion. One of my colleagues from Birmingham did some work at looking at the outcomes of pseudo double hits, suggesting that these patients may probably benefit from intensification, but the numbers are relatively small. So I think what's really important is a really good partnership with your cytogenetics laboratory. And the third question was about TDT, and I absolutely, you know, our diagnostic hematopathologists, if they look to see that the morphology looks to be unusual, and be it Burkitt-like or be it blastoid, then they would like to put a TDT on those patients. So I think if you see a straightforward DLBCL morphologically, they're kind of comfortable about that, but they'll do a TDT on those where there's some atypia in the morphology. And this caused us a huge amount of challenges, I think, from the old classification, where if you were TDT positive, you were automatically thought as being a lymphoblastic or an ALL, and these patients were going down a completely different treatment pathway. But actually, what we recognise is that TDT expression is a secondary event, and if all the other things are right in terms of the mature phenotype of the B cells, then they should absolutely just be lumped in. What we don't understand understand is the prognostic significance of TDT expression, but certainly I treat these patients as mature B-cell lymphomas and this is a secondary event.
Thank you, sir. Thank you, sir, so much for your input.
Thank you, Dr. Abhishek. Dr. Chirasri, your question, please. You're muted, Dr. Chirasri.
Thank you, sir, for your excellent talk. So I would like to know, actually, often we encounter frail patients, and DIPOC is a very intensive therapy, and MRD monitoring is not standardized in DHL. So is there any role in MRD monitoring based treatment decision? So this is my first question.
So
And
that's a really good question. Can I take that one first because I don't want to forget it.
yeah.
So thank you very much. I think you're absolutely right. I think we need to remember that the median age of presentation of these double hit lymphomas, and I should have said it a bit more clearly, is somewhere in the 7th decade of life. So of course, these older patients are going to be overrepresented, and I completely agree with you. The delivery of dose-adjusted EPOC, not only the logistics. So we give dose-adjusted EPOC, we put the bags of chemotherapy in a backpack and we give it by an infusion pump. And that's really difficult for older and more frail patients to do that. But also, of course, the toxicity, because you're trying to push toxicity, aren't you, with dose-adjusted EPOC, is a massive challenge for these older and frail patients. So really, once you get above the age of 70, I infrequently give dose-adjusted EPOC for these patients. So, and that's why I have been using R-CHOP chemotherapy, and more recently, I've been able, fortunately, to be funded to be able to use polar R-CHP in these patients. Now, the role of MRD, the jury's completely out in diffuse large B-cell lymphoma, high-grade B-cell lymphomas, etc. And basically, in clinical practice, there's no role for MRD. Now, we've seen some data from the Stanford group to suggest that maybe 20% of patients with high-grade lymphomas, including DLBCL, have MRD positivity defined by ctDNA using phase-seq at the end of treatment, and that's associated with a very poor outcome. That's only a very small data set, and we're not doing anything different as a result. There are some studies that are looking at giving CAR T cells to those patients, but this is all very experimental. So I would certainly say to you, currently in the aggressive mature B-cell lymphomas, there is no role for MRD monitoring or MRD responsive treatment.
Okay. So thank you, sir. And my second question is, in the era of novel therapies where we are using CAR-T, BITE, or in case of DHL, BCL6, vein has a very promising role. So consideration for HSCT. So where do we stand?
Yeah. So yeah, I think in the era of us using more intensified therapies, us using polar R-CHP in older patients, I certainly think stem cell transplantation has a really quite a minor role. I certainly don't think it has any benefit in those patients in a first remission, unless you have a younger patient who has had R-CHOP induction therapy. And I think that there might be a role for those patients. I think in the relapse setting, there is really very little role for stem cell transplantation in these patients now with the novel therapeutics, the bispecs, the CAR T cell treatment. And I think the role for allo transplantation, which used to be something we think about a bit more in patients who presented because of the high risk features, I think that there's pretty much zero role for allo transplantation in where we have the availability of some of these new drugs. So, as I say, allo transplantation, we still see poor outcomes and we still see an unacceptably high non-relapse mortality. So that's not really got a role in our treatment algorithms.
Thank you,
The only circumstance I can think of, and I have done this recently within the last 6 months, is I had a young man in his 20s who had double hit. He had chemotherapy, relapse, had CAR T, relapse, had a bispec, and had a complete remission to a bispec. And I've given him, and he's undergone an allo transplantation as consolidation. But I don't know whether he actually needed that or not. It's a difficult conversation. It was his decision, and he got a lot of toxicity from the allo transplant and was in the ITU for very many weeks. So I'm not entirely sure whether it's the right decision or not. But I think the role in these high-grade B-cell lymphomas for allo transplantation is pretty minor.
Thank you, sir. Thank you so much.
Thank you, Dr. Sanyal. So I think, sir, allogeneic stem cell transplant only after CAR T failed, bispecific failed. It will be the third or fourth line.
Yeah, I think so. I absolutely, and that does depend upon the resource being available. Of course, and I recognize not every territory has second line CAR T, and not every territory has third line CAR T or bispecifics available. So really, I'm always keen to say that you make your treatment algorithm in your own territory dependent upon what your approvals look like, and I think obviously importantly about what your fundings look like as well. So a treatment algorithm from one territory, from the NCCN guidelines, may not necessarily be relevant. For example, in my country, where we have a healthcare system that is resource limited. So I think you have to make your algorithms as necessary according to your own territory.
Thank you so much, sir. One question has come from Dr. Hitha B. She is a case of primary mediastinal large B-cell lymphoma, 31 years old, married, stage 4. Post 4 cycles of dose-adjusted R-epoch, all the lymph nodes went into metabolic CR, except the right pericardic lymph node, which is still measuring 4.8 into 3.7 into 3 centimeter. Post 6 cycles of dose-adjusted R-epoch, the same lymph node, right pericardic lymph node, persists now, but the size is reduced from 4.8 to 2.7 into 3 into 3. With a dual score of 4, the biopsy is being planned. If the biopsy turns out to be positive, what would be your next line of management? Should we go for autologous stem cell transplant, or should we go for medicinal RT?
Good question. Brilliant. So slightly not double hit, but when we're talking about dose adjusted epoch, I think it's really quite relevant. So it sounds like the patient has had a PET positive partial response to dose adjusted epoch. We did a study across the globe, really, called the ILSG 37 study, which asked the question about whether you needed consolidative radiotherapy in patients who achieved PET negativity after induction immunochemotherapy. And for those patients who were PET negative, there was no role for radiotherapy. Now, in the course of that study, we collected data on over 100 patients who had a Deauville score of 4 as their outcome, exactly like the story that you relate, and there was no protocol mandated approach to this, and investigators did exactly what they wanted to do, and I want to just give you a little bit of a flavor of that. For those patients who were Deauville score 4, who the majority of those patients had radiotherapy treatment afterwards. And with radiotherapy, their outcomes were the same as the outcomes for those patients who achieved a complete metabolic response. There are small numbers of patients who had reinduction chemotherapy and a stem cell transplant, and some of those had good outcomes. Not all of them had good outcomes. What we didn't know was what was left in that residual disease. Was that actually active residual disease in the mediastinal masses or the nodes, or was it just a false positive on the PET scan? It's because very few of these patients were biopsied. And where they were biopsied, there was a great difficulty because of the heterogeneity of the uptake that was seen on the PET scan. And often we get false negatives and false negatives from a biopsy because they're often very challenging to do, and we might not always get them necessarily the right place. So I would say two things. I would say that I would offer radiotherapy for this patient if the biopsy was non-conclusive for you. If you see that the PET scan demonstrates the biopsy shows residual disease, then I would offer a next line of therapy, and that would be reinduction immunochemotherapy with stem cell transplant, or second line lisocabtagene if you have that available. So I would say Deauville score 4, give radiotherapy. If I'm not sure whether you get anything from your biopsy. If your biopsy is not helpful, then I would give radiotherapy. If the biopsy shows unequivocal evidence of active disease, then I would probably take that patient to a second line systemic therapy. I hope that's helpful. that this is what to do with Deauville score 4s, I think is a complicated area, and probably we might be over treating them. There's certainly something in the read about the timeline from end of treatment to performing your PET scan, and probably that should be somewhere in the order of 7 to 8 weeks in order to reduce your false positive rate as well. So these are always very, very challenging, and I hope that's helpful for you.
Perfect. And suppose you are going for a systemic chemotherapy, the biopsy comes out to be positive. What
Yeah.
salvage chemotherapy would you offer? Because
So
this should go with our report. Yeah.
yeah, I would, if they've had dose study, I would give them a platinum-based reinduction regimen, so RGDP or RICE. Those would be my preferential choices.
Perfect, sir. Thank you so much, sir. Another question from Dr. Yimon Tent. She has got a patient who has been diagnosed as non-Hodgkin's lymphoma, but when did a bone marrow aspirate, there were 10% lymphoblast, which has been proved on flow cytometry, but the lymph node shows NHL, with bone marrow aspirate showing 10% only lymphoblast on flow cytometry. How would you approach this case?
Wow, that's very challenging. I kind of like to know a little bit more about the biopsy and what sort of category it sits in, or the biopsy, rather than just non-Hodgkin's lymphoma. But here you've got, if you think that we've got lymphoblasts in the marrow, then I think taking a standard ALL approach is probably going to be the right way to do this. But I'd obviously like to understand the phenotype of those a little bit more. So I guess I'm going to slightly duck out of this and ask if there might be a little bit more information provided, and I'd be very happy to pick this up. And please do email me with a bit more details of the case.
Sure. Thank you, sir. Dr. Pritesh Junakari has a question. Any role of intrathecal chemotherapy by any means?
Yeah, really good question. So really diminishing role of intrathecal chemotherapy for patients with high grade B-cell lymphomas. And that's because we've thought that this hasn't been effective, and a number of series have suggested that it wasn't effective. However, I was interested by that data that came out from the British Columbia group, demonstrating that actually 3/4 in patients with double hit lymphoma had leptomeningeal relapse, because the argument has been in the rituximab era that most of the relapses have been deep parenchymal. So that did make me think a little bit about whether we should start in the double hit lymphomas to think about intrathecals. So this is my practice. So my practice is for these patients at baseline. So when they first present, I will do a diagnostic lumbar puncture, and I will deliver them one shot of intrathecal methotrexate and do some neuroimaging. And then I will take them through induction chemotherapy, polar R-chip, dose-adjusted epoch, whichever we want to choose, and then I'll give them the CNS prophylaxis, just a single agent IV methotrexate at the end. I don't try and intercalate systemic IV therapy whilst giving dose-adjusted epoch or anything like that. So I think I might go away and think a little bit more about whether we ought to enhance the use of ITs during dose-adjusted epoch based upon that leptomeningeal data. But really, I think in my practice and in the UK practice, there is a really diminished role for intrathecal therapy. It's difficult to give, it's dangerous to give. There's been numerous challenges around this, and I think that the IV at the end of induction is a suitable alternative.
Thank you, sir. So any role of CNS IPA?
The CNS IPI. Yeah, I mean, yeah, of course, the CNS IPI helps us identify the highest risk groups of patients. Of course, it doesn't take into account anything about the biology of the disease.
So no matter if your patient has got high CNS IPI, would you go for prophylaxis, sir?
So I go for IV, but I go for IV prophylaxis.
IV prophylaxis.
The only time I don't, in the double hit lymphomas, the only time I don't do CNS prophylaxis is in those patients with limited stage disease.
Perfect, sir. Another question from Dr. Ravi. He has a patient who is 64 years, diagnosed as follicular lymphoma grade 2, had a complete metabolic response with R-bendamustine, completed 6 cycles of R-benda. Within 6 months, the disease recurred. Biopsy and FISH now shows the patient has got double hit MYC plus BCL2 rearranged. Went into metabolic CR with RGDP. How would you consolidate now?
So I would offer this patient consolidation with high-dose chemotherapy and stem cell rescue. Okay. I certainly believe that, of course, you're going to see exactly as you've described some of the mechanism of transformation from follicular lymphoma to more aggressive phenotypes can be driven by MYC aberrations, the accumulation of multiple oncogenic hits, including MYC and BCL2, and exactly as happened with your patient. So you've achieved a remission. We recognize from some retrospective data, I put some of this together when I did my PhD about 100 years ago, and we demonstrate that those patients who've had previous therapy then transform, have a poor risk long term and are likely to recur. And also, given the time frame for this patient, the transformation has been so short from the initial diagnosis, I would want to do something to consolidate their response. So I would certainly offer this patient consolidation with high-dose chemotherapy at this point in time. It's always difficult to quantify how much benefit that is. There's no randomized data in this patient population, but there are some retrospective studies that have demonstrated that these patients who achieve a CR in exactly the same situation as his, who have stem cell transplantation, that 60% of those will be progression-free about 3 years from the stem cell transplant. So I think it's probably worth if that's available to the patient.
And another question is regarding the conditioning regimen for double hit and high lymphoma for relapsing or for transplant. It would be beam based. Again, beam.
Yeah. So beam. Well, so beam. I use Lean actually. So replacing the carmustine with low mustine, it's just much easier on our pharmacy departments, and the outcomes are just the same. We've looked at that a number of times retrospectively. Giving the low mustine is easy because, of course, it's tablets on the first day of the conditioning, and that saves some time for the pharmacist. But absolutely standard conditionings that we would use in DLBCL.
Thank you, sir. Another question from Dr. Kiran. Many of the double hit lymphomas are also double expressor lymphomas. What are the other possible ways to achieve whether they are double expressor lymphomas or versus double hit lymphomas?
Yeah, sure. So the double expressors have overexpression of MYC and BCL2. You then do, the FISH analysis will tell you whether that's driven by oncogenic translocation. So the double expressors are essentially are from exclusion where they're not double hit lymphomas, and we need to think about and understand the mechanism of why we get overexpression of protein of MYC and BCL2 in these patients in the absence of the translocations. And there are multiple mechanisms for this. There are probably amplifications of MYC and BCL2 that do this. There are probably point mutations, and there are probably post-transcriptional dysregulation of some of the microRNAs that drive this. But it's clearly heterogeneous, and we clearly don't understand this. Now, as we've learned more about the double expressors, we begin to understand that actually their prognosis perhaps is not as inferior as we had initially expected. It represents a class of diffuse large B-cell lymphoma, NOS, that may be a biomarker for increased risk. It's not a distinct lymphoma entity. And in the new classifications, we've deprioritized things like CD5 positive, DLBCL, double expressor, etc., because of the heterogeneity in outcomes. So I don't think a double expressor requires, once you've done the FISH and you prove that it's not a double hit, then those patients don't need any particular difference, and you can treat them with conventional R-CHOP, polar R-CHP induction as you would do, or whatever your choice would be. Now, how do I select that? Well, I do FISH analysis on all of the patients with high-grade B-cell lymphoma, so I'm fortunate enough to be able to do that. But I recognize if FISH are not available to me for every case, what I do is I say I will do a FISH analysis on those patients who are double expressing MYC and BCL2 and are also of a GC phenotype, because your yield will be highest.
Perfect, sir. Thank you so much, sir. Another question from Dr. Ninmya Thanda. she has a patient who is triple expressor DLBCL and could not proceed for FISH because of some reasons.
Yeah.
Is there any role of polatuzumab if FISH is not available?
Yeah, I think that's good. I think that we probably don't know that. We can say that here we've got a patient with multiple expression, and we know that adding polatuzumab will give some benefit, particularly in the high-grade B-cell lymphomas over the DLBCLs. So I think it's impossible to quantify the magnitude of benefit. But if polatuzumab is potentially available, then I think that there's probably some benefit that can be added. I mean, just remember that the 5-year follow-up data of the Polarix demonstrates that difference in progression-free survival has been maintained over time. It's still somewhere in the order of a hazard ratio of 0.773 thereabouts, and there it looks to be with longer follow-up that although not significant yet, that the overall survival curves are starting to diverge. So if I recognize polatuzumab is a massively expensive intervention. If that was available to a patient, I would give it, but recognize that the added benefit may be relatively small.
Thank you, sir. Dr. Rashmi Kushwaha, your question, please.
Yeah. Good afternoon, sir. Thank you so much for the wonderful talk. I have
Thank
two
you.
questions.
Yeah.
I have two questions. The first one is, sir, what is your experience about those lymphomas which have overlapping features between the double hit and the gray zone lymphoma? And the second question is your experience on the role of CD99 to diagnose a lymphoma as a blastic.
Okay, so I don't have a view in terms of the diagnostic marker. Probably don't know enough about it to give you a clear answer. So I'm gonna pass on that one and go away and have a think and have a read, because I really don't know the answer to it. The first question really, however, was about sorry, did you say CD79 or did you say CD99?
Regarding the double hit lymphoma versus gray zone lymphomas.
Yeah. No, I just the diagnostic marker. I was just thinking, okay, but in terms of the gray zone lymphomas, this is always a challenge, right? So what I do is I have a really good conversation with my hematopathology colleague, and we sit down and we say, in the gray zone lymphoma, can I try and identify what this looks most like for my therapeutic choices? We will do things like FISH analysis, and if I find that there's MYC BCL2 or BCL6 aberrations, then I will treat them like standard double hits with intensified regimens, so my dose adjusted EPOC. But these are really very rare occurrences, and I think what the answer for these, anything that's gray zone, is that you have a really good conversation, you have a really detailed look at the phenotype with your hematopathology colleagues to try and find the best fit chemotherapy approaches.
Thank you, sir.
Any other question, Dr. Rashmi?
No, sir, that's all. Thank you so much.
Well, so I think so there are no more questions from the chat box. Any other discussion want to ask? Any other question? Well, so thank you so much for that wonderful talk. Excellent overview. And it was very crystal clear lecture. We learned a lot from you. I think from tomorrow onwards, the whole concept regarding double hit treatment lymphomas as well as triple hit lymphomas will be very crystal clear for all of us, and really a practice changing, sir. Thank you so much, sir.
Thank you for inviting me. It's been really great to see you. Thank you. Enjoy the rest of your day.
Thanks a lot, sir. Have a nice day.